So now we're going to switch gears a little bit and talk about frontal lobe syndrome. So we're going to talk about three in particular. The first one we're going to talk about is a lesion to the dorsolateral part of the frontal lobe. And we like to call this, or at least I like to call this, a disorganized syndrome. So I like to imagine it as someone that you're stuck working with and you really don't enjoy working with them because they just can't get simple tasks done. So they have perseveration, which is they'll stick on a specific object or question and they'll persist on that. So that's persistence. And they also have something unique called the utilization behavior, where these patients will see an object whether or not it belongs to them. And just because it's there, like this stapler on my desk, they'll just start using it. They'll start stapling things because there's a stapler and that's what you do with it. These patients also can have depression as part of their symptoms too. One of the things to look, or one of the scenarios to look for with this is a midline meningioma, midline falx meningioma. So it's just right off of the midline and placing pressure right over here on the frontal lobe. So the next one we're going to talk about is the mesial frontal, or we sometimes call it an akinetic mute syndrome. And basically these patients aren't doing very much. They're not doing much in the way of action or speech, certainly not on their own. I've heard some people describe these patients as sort of like a lump. They're just there. I sometimes have heard people also describe it like Eeyore syndrome. They're just sort of not very enthusiastic about anything. And they also have something called abulia, where they're not showing much interest in acting upon stimuli around them. This can happen when you have a lesion right down the midline. Most frequently, I like to think about if the ACA or the ACOM artery are affected, like in an aneurysm or a ruptured aneurysm. That can happen and cause a lesion right here, right down the middle. And then the third one that we're going to talk about, which is probably the most, I guess, most commonly talked about, is the orbital frontal. So this disinhibition syndrome. So these folks are just impulsive, emotionally labile. Everything is hilarious to them. They're hypersexual. They're sort of, I think Dr. Menemeyer and I were talking about it a little bit beforehand. They're almost the person at the party where you're thinking, did you actually just say that? Except they do that over and over and over and over again. And they don't quite get that what they're saying is inappropriate. So those are your frontal lobe syndromes. Let's talk next about pseudobulbar affect. I think it's worth mentioning because you may see this as you go forward in your careers. And interestingly, I think about 2 or 3 years ago from the time of this recording, there was a stream of commercials that was advertising for treatments for this. But you'll have someone who has an associated neurodegenerative disorder. So think about ALS, Alzheimer's, sometimes multiple sclerosis. And what the story is usually is this. You have a patient and they have this really almost exaggerated laughter or crying. And when you ask them what's wrong, they'll say, I don't know. I don't feel bad or sad. It's just, I'm just sort of losing my ability to control my laughter or crying. And it's really distressing to them, especially if they have issues with laughing, because in most scenarios, laughing out of the blue is socially unacceptable. You know, if someone is crying out of the blue, most people will say, oh, are you okay? But if you start laughing out of the blue, that's not going to work as well. It's also worth noting that in the last few years, I was alluding to some of those commercials, there is an FDA-approved treatment for this issue called dextromethorphan quinidone. The brand name for that, when you get out into the clinics, is called Nudexa. It works very well for this issue. And then I think we'll talk about head trauma and then concussion. A couple of things that I want to point out with this slide, sort of two of the main points. One is if you have any sort of head trauma, basically the part of the brain that gets affected will lead you to the deficits that the patient is going to have clinically. So all the things that we've just been talking about, if you have someone with a orbital frontal lesion, they're going to have your orbital frontal syndrome. If they have an issue with the temporal lobe, as we'll talk about later on, maybe they'll have some issue with memory, and we'll talk about that later on. The other thing that's worth mentioning is something called diffuse axonal injury. And clinically, what's happening is that you have a lot of pressure or a lot of traction forces. And so what's happening, instead of seeing a big visible lesion, you'll have a lot of microscopic lesions of the axons. And so they'll shear at a microscopic level. And it's notable because when you see these patients' images on head CT or MRI, you don't see any big lesions. And so you're sort of puzzled as to what's going on, why they're not interacting. So they have poor concentration, Fatigability can be an issue as well. For me in general, when I see these patients, when I think about them, I look for a patient whose head imaging is really out of proportion, looks way too normal compared to what I'm seeing on my examination with them. And then the next thing we'll talk about is concussion. So there's been a lot more emphasis placed on this in the last, I would say, 5 to 7 years or so. So the key things for me that I think about, so with a mild concussion, you don't have any loss of consciousness, and there's usually about less than 30 minutes of confusion and amnesia following that. Acutely, they'll have poor concentration, some slurred speech, some incoordination with that as well. Chronically, this is when I typically see them in clinic. The story is that they had this initial acute head injury. They feel a little bit better for a couple of days, but then I'd say around like day 3, 4, or 5, they start to feel really bad. They have this chronic post-concussion syndrome that can last weeks to months at times. They have a lot of almost vague symptoms that are really hard to nail down and treat, but we do try to treat them symptomatically. So those symptoms can include headache, vertigo, difficulty with concentration, fatigue, just everything seems off for them. And it's really frustrating because a lot of the way to treat that is symptomatic treatment for some of those things we just mentioned, but really time and rest. Also be careful, when you see these patients in the clinics, depression and anxiety can be very common after the injury as well. I think we're hearing a lot more about post-traumatic head injuries in NFL and NHL players as we go forward. And so this can be a part of that, although that's obviously something much more severe.